Connective tissue diseases. Now we will discuss connective tissue diseases. This is also a very important topic. Okay. We will basically discuss the cutaneous manifestations. Cutaneous manifestations of connective tissue diseases. Okay. First is lupus. Lupus erythematosus. This is a very important topic. You will also learn in details about lupus erythematosus in your general medicine classes. Okay. Here we will mainly focus about the cutaneous features of lupus erythematosus. Okay. It is an autoimmune disorder. Autoimmune disorder. Okay. The antibody targets nuclear antigen. Okay. Nuclear antigen is the target. We test anti-nuclear antibody most commonly. Okay. Most specific is anti-dsDNA. Okay. Now the skin manifestations of lupus erythematosus are classified by using Gillian classification. Gillian classification is used to classify the skin manifestations of lupus. Okay. First is acute lupus erythematosus. This can be localized or generalized. Next. Second is subacute. There are annular lesions and papulosquamous lesions. Third one is chronic. This is important for us. Chronic lupus erythematosus. There are various types of chronic lesions, chronic skin lesions of lupus erythematosus. First and most common is discoid lupus erythematosus. Other lesions are hypertrophic lupus erythematosus, lupus erythematosus profundus or paniculitis. This is a kind of deep lesions. Then tumidally. Next is Chilblain-Ellie. And last is LE-LP overlap. Lichen planus lupus erythematosus overlap. Okay. What we most often come across is the discoid lupus erythematosus lesions. Okay, as it is clear from the name itself, the lesions are disc-shaped lesions. Erythematosus, show there will be erythema. They are erythematous plaque, disc-shaped erythematous plaque. There is follicular involvement in the form of follicular plugging. Follicular plugging. Okay. They are covered by adherent scale. Covered by adherent scale. They heals with scarring. and dyspigmentation. Very often we see some scarred dyspigmented plaques. They are the healed lesions of discoid lupus erythematosus. Okay, most often we find this thing. Okay, see, this is a clinical picture of DLE. A disc-shaped plaque. Erythema is also visible. This part is the adherent scale. It is the adherent scale. Okay, on removing the scale, what we get? In the undersurface of the scale, there is, due to the follicular plugging mainly, undersurface of scale, we see carpet tack sign. Carpet tack sign. Okay. Okay. Now, what are the sites? Sites of discoid lupus erythematosus. It is mostly scalp, face and concha of the ear. Okay. Okay. There is follicular involvement, so there will be alopecia, scarring alopecia mainly. But we can also get non-scarring alopecia. It is commonly called lupus hair. They are short, fine hair in the frontal hairline. Okay. Next we will discuss acute lupus erythematosus. Acute lupus erythematosus. Acute LE is characterized by malar rash. Malar rash over the butterfly area of face. Number 1, malar rash. Number 2, what we get is maculopapular morbilliform rash. Maculopapular morbilliform lupus rash. Okay. Number 3, we can also get pen-like lesion. Pen, that is toxic epidermal necrolysis. Okay. These 3 types of lesions are seen in acute lupus erythematosus: malar rash, maculopapular rash and pen-like lesions. This is the malar rash. See, this is the butterfly area of face, the erythema involving the butterfly area, also of the nose, and there is characteristic sparing of the nasolabial fold. Characteristic sparing of nasolabial fold. Okay. Now, if we diagnose a case of SLE, that is systemic lupus erythematosus, there are several criteria for diagnosis of SLE. What are the cutaneous criteria for diagnosis? Number 1 is malar rash. Number 2 is discoid rash. Both of these we have seen, malar rash and discoid rash. Third is photosensitivity. Photosensitivity. Okay. And fourth one is oral ulcer. The oral ulcer of SLE is very characteristic. It is painless. It is painless oral ulcer. So whenever you will get a case of DLE, always look into the oral mucosa. if you get an ulcer and patient would not complain about the ulcer because this is painless. Okay, so if you get ulcer over the hard palate, then always suspect SLE, whether you are dealing with an SLE case or not. Okay, you have to rule out other diagnostic features of SLE if you get oral ulcer along with the cutaneous features of DLE. Okay, next what we will discuss is scleroderma. After LE we will discuss scleroderma. Okay, what is scleroderma? It is sclerosis or stiffness of skin. Sclerosis or stiffness of skin, thickening. Skin gets thickened, hence stiff. Okay, there are two types grossly. One is the localized scleroderma, another is systemic scleroderma, systemic sclerosis. Okay, localized variety has only skin involvement, systemic sclerosis you have skin plus other system involvement. Okay, now the localized variety are of two types. One is localized morphia, another is linear scleroderma. Okay, now the localized morphia is characterized by circumscribed or diffuse. Circumscribed or diffuse, remember all the adjective: hard, smooth, ivory colored, immobile, hide bound skin. Okay, so look into this picture. There is something you can see, because morphia is diagnosed by palpation. You have to palpate the hard texture, you have to feel it, the hide bound skin, you have to feel it. But what is visible here, the skin is shiny. See, the skin is shiny here. Yeah, the color, the ivory color of the lesion, it is circumscribed lesion. Okay, on palpation you will get the hide bound texture, the hard texture, the skin is smooth, hence shiny here. Okay, this is the typical description of a morphia: circumscribed or diffuse, hard, smooth surface, ivory colored, immobile, hide bound skin. Okay, now linear scleroderma. Linear scleroderma, it is present commonly over the scalp and extends up to forehead. It is present over the scalp and extends up to forehead. Okay, see this lesion, the scalp lesion, the linear scalp lesion is extending up to the forehead, and it is also same, the skin is stiffened, hard on palpation. Okay, this is called Encoupe de Saber. Encoupe de Saber, that is, it resembles saber cut with the sword. Okay, there is scarring alopecia. There is scarring alopecia in Encoupe de shiver. Okay, next we have systemic sclerosis. Systemic sclerosis. Okay, this is of two types. One is limited cutaneous systemic sclerosis. Another is diffuse cutaneous systemic sclerosis. Okay, now the limited cutaneous variety of systemic sclerosis, here we get skin thickening, distal to elbow, knee and face. This is limited cutaneous variety of systemic sclerosis. Okay, in diffuse cutaneous variety there is involvement of proximal part also and trunk involvement. Okay, now here is a very important phenomena. This is called Raynaud phenomena. Raynaud phenomena. Okay, what is Raynaud phenomena? This is a triphasic color change. This is triphasic color change on exposure to cold. On cold exposure there is triphasic color change. What are the color? We remember in this manner: WBC. First there is white or pale. Okay, second blue or cyanosis, third color or rubor, erythema. See this picture, there is pale finger. See the pale finger on exposure to cold. Then on rewarming there is bluish discoloration of the digit, and further rewarming there is erythema of the fingers. Okay, so this is the triphasic response known as Raynaud phenomena. Next, what are the features of limited cutaneous systemic sclerosis? Okay, limited cutaneous systemic sclerosis. Okay, there is another mnemonic again. It is CREST. CREST. What are those? C for calcinosis cutis, calcium deposition in dermis. Next, R, Raynaud phenomena. Raynaud phenomena. Next, E, esophageal dysmotility. We have told that systemic sclerosis is a systemic disease, so there will be involvement of other system along with skin involvement. Okay, next, S is sclerodactyly, and T for telangiectasia. Okay, in CREST syndrome we get anti-centromere antibody. Okay, now we will discuss the diffuse cutaneous variety of systemic sclerosis. See, this is sclerodactyly, stiffening of finger. See the shiny stiff finger. The finger can't be bent at the distal interphalangeal joint. They are stiffened. Okay, this is known as sclerodactyly. Sclerodactyly. Okay. Now diffuse cutaneous variety. Diffuse cutaneous variety, there will be involvement of the trunk, involvement proximal to elbow and knee. Okay. What are the other cutaneous features of diffuse cutaneous variety? The face is typical for systemic sclerosis. There we call it mask-like face. We call it mask-like faces. Okay. Whenever we at the very beginning, when we look for general survey, we have to look for the pallor, and just we pull down the lower palpebra, lower eyelid, then we can feel the stiffness of the face, the facial skin. Okay, the mask like faces. There is pinched up nose, pinched up nose, big nose. Okay, next microstomia, microstomia, loss of facial wrinkles, loss of facial wrinkles. Telangiectasia, here we get mat like telangiectasia. Okay, mat like telangiectasia. We get salt and pepper pigmentation. Okay, and other common features, that is we get Raynaud's here, we get what do we get here, hidebound skin is also common. Okay, what are the changes in hand? One is sclerodactyly, one is sclerodactyly. Okay, second is digital pitted scar, digital pitted scar. Okay, we also get digital ulcer, osteolysis. Okay, what are the antibody? Here we get ANA, anti-nucleolar pattern. ANA antibody we test here also, and we get anti-nucleolar pattern. Okay, now as it is a systemic disease, what are the other system involved? Other system, lungs, we get interstitial lung disease. Next, heart, we get various types of conduction defect. Okay, kidney, scleroderma, renal crisis. Okay, these are the other systemic features of systemic sclerosis. Okay, now pathogenesis, just a brief comment. Pathogenesis is unknown. Okay, and whenever the pathogenesis is unknown, you will get various hypotheses. What are those? One is vascular dysregulation, vascular dysregulation, hence we get vasoconstriction on cold exposure. Next, immune dysregulation, immune dysregulation, and final outcome is fibrosis. Finally we get fibrosis. Okay, so this is about systemic sclerosis. Next we will discuss dermatomyositis. Dermatomyositis. As it is implied from the name, we will get some skin manifestation and we will get some muscle related complaint. Okay, so there will be proximal myopathy. Okay, now what are the skin changes of dermatomyositis? Very important. It is a very important. See, skin is the window of our body, so diagnosis of cutaneous lesion is very important. You can prevent the various mortality, morbidity related to dermatomyositis and other systemic diseases if you can diagnose at very early stages of the disease. Okay, so what are the skin changes? Here we see heliotrope rash. What is this heliotrope rash? This is confluent, remember all the adjective here also, confluent erythematous, edematous, violaceous, macular rash. Okay, this is heliotrope rash. It is also called lilac color. Okay. Site is periorbital. Involvement in heliotrope rash. Okay. What are the other features? There will be photosensitivity and pruritus. The rash is pruritic in nature. Okay. Now, the similar confluent erythematous, violaceous, edematous macular rash is also present over shoulder. It is also present over lateral thigh, and what it is called in over shoulder, it is called shawl sign. Lateral thigh, it is called holster sign. Okay, it can also involve the V area of the neck, that is which is exposed to sunlight. Okay, next what are the hand changes? Of dermatomyositis? First is mechanic's hand. This is called mechanic's hand. Okay, what you can see here, there is hyperkeratosis, scaling and fissuring, similar to eczematous, chronic eczematous changes, scaling and fissuring, and hyperpigmentation. That is all the features of chronic eczematous lesion. Hyperpigmentation, it is present over, these changes are present over fingertips and sides of thumbs. Okay, see, the fingertips are involved. There is hyperkeratosis, fissuring, scaling, fissuring, etc. Okay, next you have two important things to remember here. One is Gottron sign, another is Gottron papule. Okay, What is Gottron sign? What is Gottron papule? Gottron sign is pink or reddish, atrophic or scaling lesion over knuckles. This is called Gottron sign. There is pink or reddish purple hue of the scaly lesion or atrophic lesion over the knuckles. This is called Gottron sign. And what is Gottron papule? This is Gottron papules. You will get flat topped, polygonal, violaceous papule over the knuckles. The area is same. Okay, you will get these lesions over knuckles, but Gottron sign, there is erythematous, atrophic and scaly lesion, and in Gottron papules you will get papule only. Next, what are the nail changes? What are the nail changes of dermatomyositis? Okay, here you get frayed cuticle. This is known as Samith sign. Okay, next, if you do nail fold capillaroscopy, what you will get? You will get dilated proximal nail fold capillary. Okay, so these are the nail changes of dermatomyositis. Now we will see another important disease, that is Behçet disease. It is characterized by three features. One is oral ulcer, one is genital ulcer, another is eye changes in the form of uveitis. Okay, in the oral cavity we will get recurrent oral aphthous. See the aphthous ulceration here, recurrent oral aphthous, the painful oral aphthous. Okay, if you get more than 3 episodes per year, per year of aphthous, suspect about Behçet. Okay, the painful oral lesion, recurrent. Then look for genital ulceration. You will get also history of recurrent genital ulceration. What is the difference between the oral ulcer and genital ulcer of Behçet? The oral ulcer of Behçet heals without scar. No scar is formed. But the genital ulcer of Behçet heals with scar. Okay? Okay. Now, there is a strong HLA association. HLA B5 and B51. They are associated with Behçet disease. This is a multi-system disease. Okay. What are the cutaneous feature of Behçet? You get 3 characteristic cutaneous manifestation. One is erythema nodosum. A common cause of erythema nodosum is Behçet disease. Next, second is you will get papulopustular lesion. You can get papulopustular lesion. Third is acneiform lesion. Acneiform lesion. Okay. See, this is the lesions of erythema nodosum, tender nodule, tender subcutaneous nodule present over lower extremity in the extensor aspect. Okay. What is the diagnostic test for Behcet? We do pathergy test. Pathergy test. It is a kind of hypersensitivity reaction. Hypersensitivity reaction. What we do is we give intradermal injection of normal saline. Intradermal injection of normal saline, and we read it after 48 hours. If there is appearance of pustule, then it is positive. Okay, so with this we end the discussion of cutaneous manifestation of various connective tissue diseases.